Yeah, great. Good afternoon. It gives me a great pleasure to be able to participate in this wonderful meeting with you all. The smile was a face that is pleasing to our eyes, has a certain degree of uniformity and regularity. Making the patient's smile look beautiful is crucial in the treatment. Because the teeth and gums are such an important part of the face, ugly teeth will never make a smile beautiful. Age is also an important factor. The factor changes with age. We must create an age-appropriate smile. Improving the balance between teeth and gums will change patient's smile and make the face more expressive. The most important thing as treating a periprosthetic case is to maintain periodontal health, stabilize tissue, and create a periodontal environment conducive to aesthetic outcome. Another important factor is the color of gingiva and teeth, which varies between individuals. Hair and skin color is also important. Selection of the proper technique plays an important part in tissue management in the aesthetic zone. This shows gingival biotypes, which are not always so clear-cut because it is difficult to determine clinically if the biotype is sequencing. However, we must be precise in a diagnosis and treatment. Our ultimate goal is to achieve harmony between soft and hard tissue or between pink and white tissues. All three cases here have illustrations. In other words, morphological balance between soft and hard tissue is of great importance in planning periprosthetic treatment. We should not just blindly follow guidelines. Instead, we must consider each individual pathological condition and communicate closely with the patient from treatment planning to proceed the best possible results that satisfy them. This shows the team member of Team Atlanta. I always feel happy about being able to work with them. I want to present a very interesting case. A 56-year-old female patient with mobility of lower right and left proximities. She had advanced periodontal disease. She had a high stick demand and wanted to save as many teeth as possible. Is it possible to obtain harmony between pink and white for patients like this? If so, what treatment options are available? These are photos of her lower face, showing crowded and flared teeth with diastema upon the lower incisors, a radial line, and anesthetic. This is a close-up, showing gingival recession and marked flaring of teeth 6 and 7, symmetry of gum line severe compromise. I draw an ideal outline for each tooth according to digital smile design. In an aggressive periodontist like this, we don't know at this point if final illustration can be placed along this ideal outline. This must be reviewed as treatment progresses. This shows the ideal outline and her initial gum line. She has about 5 mm vertical discrepancy on 6 and 7, as well as excessive horizontal embrasure spaces, not permitting placement of ideal illustrations. The key to success is to maintain overall balance by creating the appearance of near symmetry. Manufacturing review show calculus deposit and procedures in the more area. Analysis of study models allows us to evaluate what is difficult to see intraorally, such as occlusion from the ringer, arch size, action inclination, occlusal relationship, and crown width. The patients have very large defect in anterior teeth, generalized mobility, and repeated bleeding and post-discharge. Advanced bone resorption is observed in the posterior area of all 4 quadrants and in the lower anterior area. There are many teeth with root caries. The teeth with checkmark were considered hopeless. Thus, our condition is quite serious. For aesthetic improvement, many teeth require periodontal therapy and subsequent prosthodontic treatment. 2019 had ridge caries region on the back of its communication between periodontal pocket and periapical region dentistry. They published reports demonstrating that CT as useful in periodontal therapy and permits treatment assessment of alveolar bone with and depth. CT images are also shown to be more accurate and effective in determining indication for regenerative therapy and making postoperative assessment. CT imaging before and after periodontal treatment provides useful information for treatment planning, selection of surgical technique, and postoperative evaluation. Extrusion of 6 and 7 was initiated. Bone moves with the teeth as they extruded. Gingiva also moves coronally if there is no pocket. The lower arch and upper posterior area were labeled at the same time. 2002, 14, 20, and 30 were extracted, followed by socket preservation. Many people report alveolar bone change after tooth extraction. These dimensional changes make prosthodontic and implant treatment more challenging. As shown in the literature, we can control post-extraction alveolar ridge desorption to some extent by placing bone substitute in the extraction socket. From here is the stage of periodontal surgery. Periodontal regeneration was performed in the lower right posterior area. A vertical bone defect was observed on the distal of 29 and filled with a bone substitute. 213 has severe bone resorption over 2 cells of root. 15 has a vertical bone defect measured. 19 had a periodontal region from the distal at the time of initial examination. Root canal treatment led to periapical healing, increased the chance of saving the tooth. So I performed regenerative therapy and distal intraocular pocket and furcation. Severstrom et al. Had treated over 1,300 molars with fractional involvement and reported outcome after 8 to 12 years of maintenance. Survival rate was 96% for non-surgically treated molars and 89% for resected molars. Calvary et al. Divided 10-year result of treatment of fractional involvement. The rate of extraction of root resected molars was 7%. Thus, we should first consider saving teeth even with fractional involvement instead of extracting them immediately. I placed Immergain in an intraocular defect of lower anterior area and put bone graft for space making. As you can see, soft tissue and moving graft with bone. Sarama et al. Reported that 6 weeks of stabilization is needed when teeth are extracted after 4 to 6 weeks of extrusion. Proper case and technique selection is important for orthodontic extrusion. Right force should be used to maximize corneal movement of bone and gingival merging. Prognosis is better with a large amount of overcorrection. The exact duration of post-orthodontic retention period is not known, but it has shown that the longer the better. The Rama et al. Have shown proximity limitation for interdental papilla formation. Use a periodontic facility papilla formation. I manage the upper anterior dental area using this concept. There was 3 mm or deeper intraocular pocket on proximal surface of upper right posterior teeth. 4 on the parietal root of tooth 3 is resolved almost to the apex on the parietal side, which is in line with the CT finding. I extracted the root of 6 and 7 and placed bone and connective tissue graft with epithelial color. Treatment of severe class 3 defect is very challenging because ridge needs both vertical and horizontal augmentation. This method a big advantage for this type of defect. There is significant loss of attachment gingiva in the lower left posterior area. I performed FGG to improve cleanability as well as horizontal ridge augmentation in training by harvesting a thick tissue graft. This is 2 weeks post-op with good healing and adequate horizontal volume increase in 20. In the upper anterior area, I placed bone graft into the vertical defect. For 6 and 7, I did another connective tissue grafting. Interpositional grafting is a procedure with split thickness flap lies on the labial side of the defect and the subaxial connective tissue graft not completely embedded nor completely covered. Grafting thickness can be easily increased horizontally with this technique. Blood is supplied from both periosteal and mucosal side, allowing faster healing and higher success rate. Added FGG is 13 to 14 position because of gingival attachment loss and poor credibility. This shows a post-operative status. Sufficient volume was gained vertically and horizontally. Before provisional fabrication, I discussed with my dental technician to decide the design of final restoration by making another workshop. In complex perio cases, things may not as go initially planned. It is important to re-examine prosthetic design in each step, particularly before starting the prosthetic phase after surgery. What was designed with the workshop is produced with provisionals. Completed provisionals incorporating the final form, occlusion, prosthetic connection, and shade. Functional and aesthetic problems are corrected during provisional phase. X-ray evaluation is always made before final impression to deal with any problem that may be found at this stage. If there is no problem, a final impression is taken. These are advantages of vertical preparation discussed in many papers. Simple form, ease of defining provisionals, ability to correct finish line, and better marginal reputation. Controlling the periodontal tissue and using the proper preparation design facility impression taking as well. Final restoration must be managed in such a way as to ensure good periodontal health and long-term prognosis. It is important to select the type of preparation and framework design accordingly. Ito reported that abutment tooth loss was 8%. During 10-year follow-up of fixed cross-arch bridge in patients with significant loss of periodontal support, Dentistry said the risk of HPD failure was 0.7% due to periodontal disease and 2.9% due to abutment fracture. A high long-term success rate can be achieved with proper periprosthetic treatment and supportive periodontal therapy. The Fabo reported 9.9% or 20 tooth loss in FPD cases. Final restoration, which are fabricated by team member Mr. Katsuhiro Hatate. I'm really grateful for his excellent work as always. Upper anterior gum line is nice and harmonious. 6 and 7 with significant gingival recession and poor anesthetic before treatment were nicely improved using Prosthesis. The occlusal view also shows a balanced gum line because the remaining teeth are still somewhat mobile. A sprinted design was selected. For the lower anterior area, although I proposed prosthodontic treatment for stability and elimination of black triangles, the patient did not want the treatment. However, the teeth are stable with less than 3 meter pocket, no BOP, and full mouth product score of less than 10%. X-ray after placement of final restoration showing nice and even bone levels and clear lamina dura. Comparison before treatment after final restoration. The retroclined upper and lower incisors, the extruded lower incisors were corrected. The occlusal plane was also improved. Pink and white aesthetic are harmonized, providing continuity of the dental arch. These 7 teeth, initially regarded as hopeless with a check mark, could be saved and remain in good condition. 6 and 7 were extracted, but the bone level in the upper anterior area remains favorable. I believe that the patient's desire to save as many teeth as possible have been fulfilled. Many studies show that the most teeth can be retained even in advanced period cases with periodontal treatment and regular maintenance. Lind et al. Reported only 2.3% of tooth loss over 40 years in 61 cases with regular maintenance every 3 to 6 months. According to the initial DSD design, I had to write the gum line for 6 and 7 about 5 mm to obtain ideal outline of prosthetic design, but I think I could achieve a relatively satisfactory result in the end. Comparison of her smile. She is very satisfied with the results. She looks younger with a nice spontaneous smile. They are my mentors I admire. I wouldn't be here without them. They always give me advice and inspiration. What they have in common is passion. I always strive to track on my work with the same passion as they do, and cherish a spirit of challenge. When treating a case like this with multiple complicating factors, our final result may not match our initial diagnosis and treatment plan. It is important to constantly re-evaluate it and search what is best for the patient through our treatment, so that we can produce better results for the patient and the doctor. The treatment plan I present today is just one of many possible options. I hope you will find it informative for your practice from tomorrow. Thank you for your kind attention.